Good morning. This is Fred H. Brennan, Jr., DO. I'm from the University of South Florida, the Morton Plant Bay Care Family Residency, as well as Sports Medicine Fellowship. I am presenting this lecture today on the MSK Radiology project, our radiology project for family medicine residents. And this is a presentation on reviewing tib-fib x-rays, tibia and fibula x-rays. It was put together by Dr. Eric Pettyjohn, who did a great job with this presentation. And so I'm going to be recording it for him. And we're basically going to go over the common findings of looking at a tib-fib x-rays, a little bit of clinical correlation as well. So we're going to get started. First, our objectives. We're going to look at the x-rays of the tibia and the fibula, just a systematic approach to looking at that. We're going to look at 3 common adult findings, including tib-fib fractures, and sort of a systematic, again, approach to looking at the entire tib-fib. Then we're going to talk about some basic clinical conditions that may be associated with these things. So first of all, common views of the lower leg, looking at tib-fib x-rays. We're going to look at an AP view and a lateral view, and we're going to go over a systematic approach to reviewing these x-rays, both the AP and the lateral, as well as potentially an oblique view. So looking at the AP view, we have here looking at some of the common findings of the tibia. We got the medial and lateral tibial plateau. We're going to follow the cortices all the way down medially, looking for any irregularities, especially if there's trauma involved, as well as if there's potential infection, looking for periosteal elevation or of a stress fracture. We've all heard of the dreaded black line in the mid-tibial shaft, looking for any signs of that, and really based on the patient history, whether this may be an issue or not. If it's a runner who's putting in multiple miles during a week, changed in training, we may be more suspicious for a tibial stress fracture. We're going to look at the lateral tibial plateau. We're going to go down, looking at the cortice all the way down, the cortex all the way down to the ankle joint, the tibial plafond, the medial malleolus, the fibula, now the lateral malleolus, looking at the lateral shaft, and then the medial shaft, looking for any irregularities in the cortex, as well as the fibular head and the fibular neck. Don't forget the femur, the medial and lateral femoral condyle, looking for any loose bodies, calcific loose bodies that might show up. Remember, if it's cartilage, it might not show in there, but if it's calcified, it will show potentially. And we're going to look at the talar dome back at the ankle, at the talar dome for any signs of a fracture. So it really clinically depends on how the patient presents. And we always talk about is when we order an x-ray, giving the radiologist as much history as possible, whether you're suspicious for a stress fracture or you're suspicious for infection or whatever you're looking for, really give the radiologist a heads up. That way they can help you. Remember, they don't have the patient in front of you or in front of them to be able to really focus in on one particular spot. So giving them a history of where the patient hurts and what the mechanism of injury was, or if you're suspicious for a stress fracture, this really helps radiologists, which eventually, and in the long run, helps you. So here's our tibia and fibula series. We have an AP and a lateral, very common. That's usually your standard views. And here's a lateral view here with the patella, tibial plateau, anterior cortex, tibial tuberosity, or tibial tubercle, some people will say. Look at the posterior part of the tibial plateau, the posterior cortex all the way down to the ankle joint, and then look at the fibula again, the fibular head, and go back and forth down both sides of the cortices. So really the issue is having a systematic approach, whether you're looking at the femur and going on down, whether you're looking anterior and going on down, and then coming back up and posteriorly, whatever your technique is, just be consistent with looking at all the cortices, the tibial plateau, the femur and the femoral condyles, the patella, the tibial shaft, the fibular shaft, all the way down to the ankle joint. Just a nice systematic approach, whatever works for you. And I think the key for x-rays with digital x-rays is sometimes we get so focused in on one area, we forget to look above and below. So make sure that you scan and drag the digital x-ray up and down so you make sure you see the entire thing. And don't forget the soft tissues as well, looking at the soft tissues here, for example, the gastroc and soleus, and the soft tissues over the anterior cortex of the bone, looking for any signs of subcutaneous air, which might lead and you might be looking for an infection or potentially an open fracture. Here we have 3 adult conditions that we often see: tibial shaft, isolated fibular fracture, and a tibial plateau fracture. You don't have to remember this classification scheme, but when you're looking at the tibial shaft, just remember that it's going to be a simple fracture, a wedge fracture, or potentially a complex or a comminuted fracture. So again, the best thing for you to be able to do is to describe what you see. Is it transverse? Is it spiral? Is it oblique? Is it displaced? Is it non-displaced? Is it open? Is it closed? Meaning the skin is broken or it's not broken. This is really the key to describing these fractures. If you don't remember the classification scheme, that's okay. But when you're on the phone with a consultant, you need to describe what you see for a fracture. And so don't get too hung up on the classification scheme, but you should know that it exists. Here's a nice example of a transverse fracture here, mid-shaft, both of the tibia and the fibula. It's non-displaced, the minimally displaced. The tibia looks like it's somewhat comminuted, multiple fragments. This looks like it's just 2 parts in the mid-shaft. I actually had one of these fractures myself of just isolated fibular fracture where I got hit by an opposing football player. His helmet hit me right in the mid-shaft of the fibula, and I didn't know it was broken for about 3 weeks. It hurt, but it wasn't until I eventually went to the emergency room on a cold, rainy day and realized that this was more than just a contusion. There's a spiral fracture, distal tibia. You can see it on the lateral, on the AP. Make sure you check the fibular head as well. You can see this is a scale to the immature person. You should also note that we're not focusing on pediatric injuries on this particular series, but you'll see the open physes here, and you should note the open physes here distally of the tibia fibula, like in that talar dome and the tibial plafond, and again, the open physes in this particular one. Here's a comminuted fracture, multiple pieces, both of the fibula and tibia. Again, another scale to the immature person with the open physes of the tibia and the fibula. So with these tibial plateau fractures, male more common than female, young usually it's associated with a high energy injury, older usually a fall. You want to inspect the entire length of the extremity from the knee down the tibial shaft, the fibular shaft to the ankle. Look for swelling. Inability to weight bear is always a red flag. Always think of a fracture if they can't weight bear. When you have a tibia fracture and or a fibula fracture, or definitely a both bone fracture, you want to be looking for signs of compartment syndrome, and tight compartments, pain out of proportion to the exam, hematomas, etc. And of course, always do a good neurovascular assessment. Anytime you manipulate, you should do a good neurovascular assessment before. Anytime you immobilize or splint, do a neurovascular assessment before and frequently after. Here's an isolated fibular fracture, sort of proximal to mid-third. Same here on the lateral. This is more of a Mason nerve fracture where you are associated with an ankle injury. Usually it's sort of a high ankle mechanism where the foot gets everted outwards as opposed to an inversion sprain. You have disruption of the mortise of the ankle. You can see the widening of the ankle joint, and the force gets transmitted up the fibula and blows out more proximally. So anybody with an ankle injury of any sort, whether it's inversion or eversion injury, you should palpate up the entire fibula and the entire tibia, feeling for any tenderness, because as we know, sometimes a distracting injury distally at the ankle, they won't even notice the pain more proximal unless you examine for that, and you might miss it. We've all had cases present to us, I think, where this has potentially been missed because of the distracting pain down below at the ankle, and no one assessed up more proximal, and they come in a few days later and go, boy, it hurts by my knee too. And then you get this, and you find that Mason nerve type fracture with widening of the mortise, as well as the proximal fibular fracture. Tibial plateau fractures, various types: non-displaced, displaced, depressed, non-depressed. You can see the fracture here, the lateral aspect here of the tibial plateau. You see a hemarthrosis. Anytime you see a hemarthrosis or an effusion of the knee post-trauma, you need to suspect an intra-articular injury, whether it's a fracture or a significant ligament injury. And the oblique views do help you here. So if you have trauma, a fall from a height, car accident, etc., you should definitely do an AP, a lateral, and an oblique view, because the oblique view does give you another angle of the tibial plateau, which you can see the very subtle fracture right here, which is non-displaced or non-depressed. So in summary, tibial shaft fractures, you always want to look for a secondary fracture, whether it's of the ankle joint or the fibula, especially with high energy, like a car accident or a fall. And you want to definitely do x-rays above and below the tibia or the fibula. If there's pain at the knee or the ankle, get dedicated x-rays of those particular joints. Isolated fibular fracture, like for myself, it was a direct blow to the fibular shaft. It may be from an inversion ankle injury, and always examine all the way up the entire fibula for signs of Mason nerve fracture, especially if it's a high ankle mechanism, meaning an eversion of the ankle and foot. And the tibial plateau fracture, you usually have an effusion, usually difficulty to inability to weight bear, usually high energy fall, but not always. And it's not uncommon to get a CAT scan, a CT scan after the x-rays if you suspect it or see it on the x-ray to really assess whether it's depressed or non-depressed, displaced or non-displaced. Your orthopedic partners are going to probably want a CAT scan to further assess the degree of the tibial plateau fracture. And that's all I have today for you. Hope you found this helpful in reviewing tibia and fibula injuries, and we have more to go on this musculoskeletal radiology series for our residents and fellows. And again, hope you enjoyed it, and appreciate your attention.